My name is Mark Rosenzweig. I'm a patient. I'm in my 11th year with ALK. And we started this ALK-TALK series about 5 years ago. And there's about 70 plus ALK-TALKs that we've done so far. And I just want to say that we have a lot of YouTube videos. We have our own YouTube channel, which we'll post in the chat. And you can go and check these videos out and our other videos that we might have. So it's a great way of learning. And Summer just posted that. So what I'm going to do is I'm going to go ahead and start our questions. And so the first question I'm going to ask is, when were you diagnosed? How many years are you into this disease? Share the results, and Summer, take it away.
Okay, when were you diagnosed? Under a year, 9% of us. 1 to 2 years, 7%. 2 to 3 years, 30%. 3 to 4 years, I fall in there, 33%. 6 to 7 years since diagnosis, wow, 12%. And 8 to 9 years is 5%. And hold on, let me scroll down. And then we have 10 years or more, 4%. Fabulous.
Okay. And the other couple of questions here. So what type of treatment are you receiving currently? I mean, and the poll, share the results.
What is the type of treatment you are receiving? 4% of you are on chemo and a TKI. 61% of you are taking alectinib. 13%, myself included, are on brigatinib. 17% lorlatinib. 4% straight chemo. 2% a clinical trial, and everybody here is on some, or their loved one is on some type of treatment, so 0%.
I was going to ask some radiation questions, but we'll find out more about radiation. That's why we have our ALK-TALK. But some of us have not received radiation ever. Some of us have, and some of us have received it at the very beginning of treatment, and some of us have received it during progression. So I thought it would be a great idea, and Summer's brought on some special doctors to talk to us, and take it away, Summer.
Thank you so much, Mark. Hello, I am Summer Farman, ALK-positive patient since the summer of 2020. And I pretty much have been volunteering ever since. I find it so therapeutic to give back and to work towards empowering and informing our community. So glad to have you all here with us tonight. And it is my pleasure to introduce a special person that is here with us, Suzanne Husseini. She joined ALK-Positive Inc. this past August. And in such a short time, ALK-Positive is already a better place with her in it. We have learned so much. She comes to us with a plethora of experience from academia and from industry. So we are so fortunate to have her leading our charge. You all will get to hear, you're going to hear a little something now, but you'll get to really meet her in October, on October 6th, mark your calendars, for our lung cancer awareness / research talk that we will be having. So Suzanne, please say hello.
Thank you so much, Summer, for this kind introduction. It is so great to meet you all. I know I've met some of you at the summit. I met some at the World Lung in San Diego, and I look forward to meeting everyone and working with you. Thank you so much for the trust you place in us. Thank you for your partnership and for your support. Since my arrival, it has been a source of inspiration to know that, or to commit ourselves to advocating for you all, for our patient population in every room, at every table, in every opportunity. And I am personally deeply committed to searching for and funding the most promising biomedical research in hopes to change the odds for so many diagnosed with ALK-positive lung cancer. Thank you so much for having me here with you, and I look forward to future engagement with all of you. Thank you, Summer.
Thank you, Suzanne. So we just decided this past summer we wanted something special to kick off season 5. Um, and I had talked with Matt Quirk. For those of you that don't know Matt, he was on a panel at our summit. He's an ALK-positive patient, but he also happens to be an assistant professor at the UCLA in their Department of Radiology. He's also an interventional radiologist. So this hits a little close to home. And a hot topic that we see constantly in our support group is radiation therapy. What's ablation? What's the role of an interventional radiologist? What's on the horizon? Where are we going with radiation oncology? What's LCT? Is LCT right for me? So all questions on the hearts and minds of many of us. So Mark introduced me to Dr. Drew Moghanaki, who is not a stranger to ALKtALK. He's actually been here. He's presented at our summits. I just had the pleasure of meeting him recently through email. So we're so excited to have him here tonight. He is the professor and chief of thoracic oncology, one of Matt's colleagues at the UCLA Department of Radiation Oncology. So we are so excited to have you both with us tonight. Thank you. Take it away.
All right. Well, thank you so much for having me here. I'm hoping that there's some useful lessons from this presentation. I do see a hand that's up. Did Robin have a question? Or should I just go ahead and begin? All right. Well, I'm very involved in advocacy for a variety of reasons. One is because of the way that I was raised by my parents, and the second is basically the passion that I had for taking care of people when I sat in my chair as a first-year medical student, that despite all the challenges and difficulties that a clinician may face in the U.S. healthcare system, I never wanted to let go of. So I'm going to talk about when tumors won't disappear, but real quick, I do want to mention that I've grown fond of working with your group ever since Gina introduced herself to me at various conferences, and basically made me commit to never forgetting about the value of advocacy. So Gina, we miss you. So tonight came up with a catchy title because I think at the end of the day, this is the patient-centric view of the situation. You've got scans, you've got tumors, you've taken drugs, but they just won't disappear. So as mentioned, I'm a radiation oncologist, and most of you, if not all, already know Dr. Quirk, who I work with very closely at UCLA. So I want to give an insider's perspective on multidisciplinary care, and I hope that in the next couple of slides, you'll be convinced to always seek a multidisciplinary team. And that's because lung cancer is complicated, and it's crucial for everyone to be on the same page. I hate to admit this publicly, but yes, there are diagnostic uncertainties. We look at scans, we look at test results, and we're not quite exactly sure what we're looking at. So we need the experts in the room. Let's say a bronchoscopic biopsy was done and the pathology report comes back uncertain. Well, we need the pulmonologist to tell us what happened during the procedure. We're looking at scans. We need the radiologist to tell us what is your best guess at what we're looking at, because the report says, basically not sure what it is. Then there's PET scan interpretations and, of course, biopsy interpretations. Then when we finally sort out what exactly we may be dealing with, or with a high level of certainty but not exact, we then have multiple treatment options. And in our team, I'm very pleased and proud to say that our interventional radiologists are part of the discussions on Friday mornings when we have our tumor boards, because in many situations, we don't just need them to do more biopsies, but also to deliver local therapies for tumors that won't disappear. This is kind of what it looks like for us if you actually are a patient seen in our clinic. I know that there's at least a few other, but I'm not sure how many academic or even community centers where a patient can come in and see every thoracic specialist at that institution kind of in a one-stop shop setting. And for us, that's every Friday morning. And so here you see in the middle is a thoracic surgeon. You've also got an interventional pulmonologist, a couple of medical oncologists, a couple of radiation oncologists. And what's key is you also have an advanced practitioner to help kind of keep on track of all the different tests and additional appointments that have to be made, because people forget. And all of a sudden, the patient's calling back a week later, hey, whatever happened to this test or that appointment? And so kind of that team efficiency, when you find one, stick with them. And the alternative journey really is not desirable, where you see one doctor on one day and then 4 days later, another doctor some other day, and then they may or may not even know each other, but they have great reputations. I actually think the reputations of individuals pales in comparison to the reputation of a team. Find a strong team that works together. You're very likely to get better care than shopping around for some surgeon that has a higher reputation or some radiation oncologist that has a higher reputation. Team-based care is the best way forward. So along this topic of treating tumors that won't disappear, I want to just clarify misconceptions that I often encounter in my conversations with patients. And that is that no matter what scan you get, there will always be invisible disease if you're already diagnosed with stage 4 disease. So I'm not going to talk about stage 1, 2, or 3 at this presentation. That would take a lot more time. But just to point out that the PET scanner, as pretty as it is, so on the left is a PET, in the middle is a CT, and on the right is what we call a PET-CT fusion. The PET scanner was invented during the Cold War in the 1970s. We've had very little progress ever since, maybe some improved scanner sensitivity and spatial resolution. But at the end of the day, until there are millions and millions and millions of cells in a single nodule, the PET scan can't see it. So clinicians are often making their decisions based on research data, what we know will very likely happen, and not knowing if there is invisible disease as a yes/no question, or if there is, how much there is, or if there is invisible disease, what its biology is. That uncertainty forms the basis of the uncertainty of benefit for local therapy. The local therapy can only be aimed at visible disease that we see, and the biggest conundrum is we just don't know what's going on with the invisible disease. And many of you may be wondering about invisible disease in the brain. Well, MRIs are actually quite sensitive, but they too can miss subclinical lesions. That's why we often are getting MRIs repeatedly every 3 or 6 months, depending on the clinical scenario. For example, if a disease is uncontrolled outside of the brain, we probably want to keep a close eye on the brain. But again, for the purpose of this talk, I'm going to skip over the brain, because generally when we have visible disease in the brain, that requires kind of a separate dedicated conversation, and stereotactic radiosurgery or surgical resection can be considered. So coming back for the rest of the talk, I'm going to talk about disease outside of the brain that's visible, given the uncertainty of what's going on with the invisible. Now, academicians are interesting people. We like to be intellectuals, and a surgeon once reminded me what the definition of intellectual is. And that is we somehow almost are rewarded for taking things that are simple and making them complicated. There are at least 8 different definitions of oligometastatic disease, and there's no scientific cutoff for the number. It could be less than 3 or 5 or 10. There's actually randomized trials looking at people with more than 10 metastases, still calling them oligometastatic. So I don't know where the cutoff is, and the scientists who even coined these terms are now publicly stating, yes, they just took a guess. No one really knows. There's not a lot of scientific data for where a cutoff should be. Next are all the different terms. Like I said, there's like 8 and more. I just think there are 2 that are really useful for conversation to simplify the language. For oligometastatic disease, either the tumor is persistent and not going away, or the tumor's present and progressing. And these 2 categories have formed the basis for the populations being studied in randomized trials of local consolidative therapy. That is, should we sweep the rear and clean up whatever's still persistent that the drugs didn't eradicate, or should we wait until the disease is progressing and treat at that time? And there are uncertainties for both classes of patients. And the key thing is summarized in the bottom, because the purported benefit of local therapy depends on 2 key issues. The visible disease that we see and may or may not be glowing on a PET scan. First of all, is it alive? Second, is it shedding? And more commonly, we're getting liquid biopsies where we're seeing genetic biomarkers of TKI resistance, and we're wondering, is that coming from the visible disease or the invisible disease? A very important study question would be, would eradicating visible disease make that liquid biopsy test result go negative? I'm unaware of any studies that have been designed that way, and we at UCLA are already talking about designing such a study. The second thing, as I mentioned, is again this uncertainty. Is invisible disease otherwise under control, or is whatever we're seeing on the scan just the tip of the iceberg, and we're just wasting everyone's time, burden, finances, and of course, side effect risks by treating what's visible when we can't control what's invisible. So the benefits of local therapy for stage 4 lung cancer, ALK positive or not, really, I think the number one benefit is to get more mileage out of effective and systemic therapies that are going to be your best line of treatment, because there generally are not a lot of other good treatments left. And also, we know at some point, sad but true, whatever drug therapies patients are on, if the disease hasn't been eradicated, there will come a time where there's systemic therapy intensification. And as Jill Feldman, who many of you know, reminded me earlier today, it also intensifies side effects. So how can we use local therapy to delay and prolong the best quality of life possible? Well, when it comes to local therapies, there are kind of three main treatments. And fortunately today, they're all minimally invasive. So on the left, while the patient's asleep, video-assisted thoracic surgery with VATS or robotic, can go in, remove. Generally for stage 4 patients, we're not doing lobectomies. We're just doing wedges or segmentectomies. I think it's just too much treatment to go after an entire lobe, although there may be some exceptions. And these patients can generally go home within a few days when everything goes well. And the key to success with surgery is picking the right patients who are healthy and fit so that they don't have complications and, for example, go off of systemic therapies because they're dealing with a surgical complication. The second, another minimally invasive treatment, outpatient, does not hurt. Patients lay on a table and this machine rotates around them. And these days, often it's basically treating that, it's aiming a very small beam, focused on a tumor as the machine rotates around them. And then the third, slightly more invasive, but still considered minimally invasive by yesterday's standards, percutaneous ablations that can deliver cryotherapy or microwave ablation. Here is an example of stereotactic body radiation therapy on the left, and on the right, showing how we can actually treat multiple tumors. But there generally does come a limit to how many that we can treat, especially in the lung. The highest number of tumors I've heard of being treated in the lung was 10, and even that's a bit excessive. So I think we try to keep under 3 to 5 in a person's lifetime, if possible. And that's where a percutaneous ablation comes in as an advantage, because it can treat more and more tumors, perhaps safer. So let me fix this slide because I want to show this very important clinical trial ongoing at MD Anderson. Sorry about that. So Yasser El-Amin is a medical oncologist at MD Anderson, and actually generously agreed to give a presentation at a session I moderated earlier this year on the use of local consolidative therapy for oncogene-driven lung cancers. And some of you may already know about the Bright Star study, but here are the slides from his presentation, summary after he presented the data at World Lung back in 2023. And you can see John Haymack is the senior author and champion for this study. So at MD Anderson, they believe in local consolidative therapy in patients with whatever oncogene, whatever TKI. Generally speaking, after a few months of treatment, are sent to radiation oncology to have the radiation oncologist clean up any sites of oligopersistent disease. And this is a controversial area, and I'm glad that they're studying this in prospective fashion, as here in the Bright Star study. So as we know, brigatinib was approved before alectinib back in 2020, and so that was a standard of care, and patients receiving brigatinib for just a couple months after restaging and without progressive disease were basically sent to get local consolidative therapy. And here they basically said if there was 3 or less active sites, then local consolidative therapy to all 3 sites. And if it was more, they left it up to the physician to see if they really wanted to try to treat everything. And there's a lot of judgment in knowing when SBRT or, for example, surgical resection might be safe. Depends on tumor size, location, and patient status. So here, in this study, I'm unaware of ablation being studied. Now, I'll tie this all back to ablation at the end, where we can draw on the data from these studies to basically think of all local therapies as relatively equivalent with regards to efficacy. So on the left, you'll see that most patients were treated with radiation therapy, some with surgery, and a few actually with both in common. And then on the right, the details of SBRT. IMRT is kind of it's intensity modulated radiation therapy. It's a longer course, maybe 4 weeks or 6 weeks. And then there was a patient that was treated with proton therapy available at MD Anderson. And a lot of the patients actually had their brigatinib held. We're not sure if it matters or not, but we often will do that. And finally, they see the types of surgical resection done. So 3 were deemed probably had large, bulky tumors, not safe for radiation therapy, in whom lobectomies were done. And you can see that the disease was not limited to the lung, where one person had a persistent disease in the adrenal gland that was resected. So generally speaking, we would not be zapping tumors that we can no longer see. These are persistent sites of disease that will disappear. Here was the safety of the local therapy. You can see the severe adverse event rate was marginal, just basically 1 patient in each of these severe complication categories. And again, this plays out to the careful patient selection. We should not be just kind of pressing the pedal and delivering it to any patient, but instead carefully selected patients who are eligible. So in patients who got 2 months of brigatinib followed by LCT, this is the time that they were able to stay on brigatinib before they had to switch. Are these results good? Well, depends what you compare to. So the ALKtALK trial on the right was a first-line single-agent brigatinib study, and you can see the progression rates at 1, 2, and 3 years for that drug alone versus in BrightStar, that drug plus LCT. Now, we always have to be careful. This is not a randomized trial, but it does provide a good signal that we at least are not worsening disease. So, for example, there is some laboratory data that shows if you zap a tumor, somehow it may cause other tumors to grow faster. That basically did not happen in this real-world clinical trial setting. Now, what's interesting is the predictors of outcome. So the patients on the left, those who did best, basically only had a few sites of disease versus lots of disease at the time of diagnosis. So that's oligo disease versus polymetastatic disease. Next, your extent of local consolidative therapy, if they needed to, if they were able to treat all of the disease. So the blue line is complete LCT, and then the red would be, 3 or more lesions where they didn't treat all the sites. And total metastatic ablation is something that we often talk about, and there's other data that basically supports the same thing. So if we're going to go for it, we really should be chasing down everything that's visible to get the maximum benefit. Because again, if the persistent disease is shedding, we want to knock out everything to be sure we get everything that's possibly shedding. And then finally, the ALK status, again, these liquid biopsies suggesting that if you do have a shedder, they're more likely to benefit. So trying to now piece this together when we do want to give local consolidative therapy, should we do surgery or SBRT or percutaneous ablation? These are the most recent and kind of largest series that I'm aware of out of Mayo Clinic, which looked at 644 patients with a variety of different cancers. So this is not just lung cancer, but it's about treating tumors in the lung to get a sense of what are the practice patterns at a large institution like Mayo. Here they had 7 hospitals contributing data to this experience. And you can see bottom left, performance status is 0, so that's ECOG 0, basically healthy, no symptoms from your disease. Patients who went to surgery, almost all of them were in that kind of a shape. As is often our experience in radiation oncology, about half of our patients had really good health status. The other half had some symptoms or decline in their activities of daily living. And then similarly, the percutaneous ablation, because again, it's a little bit more invasive SBRT, much more likely to actually have that healthiest baseline status. The tumor sizes that were treated at Mayo, the tumor sizes were generally larger that were referred for SBRT. Tumor location, interestingly enough, when tumors are more central, for surgery, you have to take out more lung because you kind of have to, it's like cutting off a branch of a tree. If it's near the trunk, you got to cut it just before the trunk, and everything downstream from it has to go. And then percutaneous ablation, less likely to be central as well because the needle has to go farther, and that can create its own challenge. But SBRT, because it's high energy X-rays, can kind of aim at anywhere in the chest. The risk of severe complications were not any different between the three. SBRT may be a little bit higher and percutaneous ablation may be a little bit lower. But this does not include pneumothorax, which is not considered a severe complication. So we know that all patients who undergo surgery end up with a pneumothorax and a chest tube, and some patients undergoing ablation may end up with a pneumothorax or chest tube. But just for fair comparison, we didn't want that to be misleading. And basically, it's part of the journey that's always included in the consent process that a patient may end up with a chest tube after those other procedures. These are the data showing local control. Now, we got mixed histologies, and that may be confounding it, but you can see there on the blue line, radiation therapy did extraordinarily well with a very low rate of recurrence, although it is said in the article, and Matt, Dr. Quirk and I know this, that sometimes we may be underscoring recurrence because after SBRT, it leaves a nice little scar around the tumor that we just kind of kick the can down the road, assuming that it's not progressing. But nonetheless, these scars, fortunately, don't cause any significant symptoms for patients. And then also what's interesting just to share with this group is that a lot of patients did have more than one course of LCT, including some having 3 or more courses of LCT. Again, try to get that benefit of staying on their first-line therapy longer. So radiation oncologists love to do randomized clinical trials, and comparing SBRT to no SBRT, you've got a bunch of, basically from left to right, here's a group of patients with what we call induced oligometastatic disease. So let's say they show up 20, 30 metastases, and then there's like 5 persistent, that's called induced. And 1, 2, 3, 4, 5, 6, 7 randomized trials evaluating it. On the next, you've got upfront oligometastatic disease. Then you've got patients with oligopersistent disease and then oligoprogressive disease. And we're seeing mixed results from these studies. We're seeing some showing significant benefits and others being negative. And so the data, unfortunately, remain a little bit fuzzy for us to sort through. So finally, I want to share 2 pictures that Jill sent me earlier today. Jill is someone who has benefited from local therapy to optimize her journey. Her first course of SBRT was now more than a decade ago. And at one point in journey, she was able to stay off of TKIs for 5 consecutive years. There had been only 1 lesion. It was zapped. She decided she didn't want to deal with the toxicities of her TKI at that time. And only 5 years later, there's something new emerged. And she actually was treated again just this past May in 2024 and is doing great. No shortness of breath that I can determine. And so I'm just so glad that we have this treatment available, these treatments available as we wait for better systemic therapies to be approved.
Drew, that was great. Thanks for that talk. That perfectly frames what I was hoping to do, which is just jump in really quickly with a few slides about tumor ablation and how that can fit into an LCT paradigm. Oops, before I do that, I've got to share my screen, huh? And then hopefully we'll leave most of the time just for discussion and answering questions. I'm really just going to talk about ablation. So I'm an interventional radiologist. Sometimes people don't know what the difference between a radiation oncologist and an interventional radiologist is, but basically I use CT scanners to get needles in places, and Drew shoots in x-rays from the outside. So that's the main difference between us. But I do a lot of biopsies and other minimally invasive procedures. One of them is tumor ablation, where we stick a needle percutaneously just through a pinhole in the skin into the lung or another organ to treat small tumors like this little small lung cancer that we went in with a microwave ablation needle and just burned it. And that's a way of destroying the tumor. And what we see when we follow that tumor over time is that it just sort of forms a scar in the lung. In this case, it forms sort of a cavity full of air, but we follow that over time and see that that tumor is dead and doesn't recur. These are some of the ablation modalities we use. That one we just saw was microwave ablation, so that's a heat-based modality. These procedures are done as an outpatient procedure. You go home the same day. They're done in the CT scanner under conscious sedation. They don't require anesthesia because the lung doesn't feel pain. This is what it looks like. So this is a patient under these blue drapes here, and one of our fellows is placing the microwave ablation probes into the lung. And then after that's done, the patient's going to move into that CT gantry and take an image and see where the probes are and adjust them to be just right. So we can create this ablation zone here that kind of grows back from the tip of the probe. We position them in and around the tumor in such a way that we're able to burn the entire tumor and get a treatment on it that way. Here's the other modality that we use fairly often, cryoablation, where we treat tumors with cold. You get them cold enough, you're pretty much immediately cytotoxic when you get down to about minus 20 degrees Celsius. So some of the advantages of cryoablation is it's less painful than the heat-based modalities. And it's a little safer in terms of preserving vital structures. If you've got a tumor right next to the diaphragm or the trachea, something like that, sometimes cryoablation is a little safer option. The trade-off is it does cause more bleeding than the heat-based modalities. But otherwise, it's pretty similar, just a matter of positioning these probes where they need to be and confirming where you are on CT scan. You can see the frost forming on these cables. The cables get pretty cold. And whether you've done a radiofrequency ablation, which is the older modality we don't use so much anymore, or microwave or cryoablation, the result is pretty much the same. You form a sort of scar that delineates your treatment zone in the lung that collapses down over time, sometimes forming this kind of a air-filled cavity and other times not. But we always follow it with serial CT scans to make sure that we don't have a tumor recurring there. The goal, of course, is to induce cell death within a designated target volume of the lung. And we always include a little bit of a margin, at least half a centimeter to a centimeter around the tumor, just to make sure we've got it in its entirety. We want to be an accurate and reproducible therapy. We want to spare as much of the normal lung as possible. And we want to avoid damaging any vital structures like nerves, great vessels, things like that. Indications for ablation, of course, provides only local control of tumor. So you're only treating that one tumor that you treat. So for early stage lung cancer, stage 1, you can do ablation alone. We would only do that in a high-risk population that wasn't eligible for surgery. And for any higher stage, 2 through 4, should be combined with other therapies. You could do it in the setting of oligorecurrence, like Drew talked about. After other treatments, surgery or radiation, you can go in if there's a recurrence and do an ablation to treat that. Or if there's a recurrence after systemic therapy, chemo, immunotherapy, or TKI, like we're all on. What we're talking about today is local consolidation after a partial response to systemic therapy, LCT. You can also do it in the setting of local progression, oligoprogression, or limited low volume metastases, oligometastatic, and Drew talked about the definition of that, or lack of one. Here's a case that I saw recently in follow-up, so it's a good illustrative case. This was a 66-year-old man with metastatic lung cancer on immunotherapy, and his PET CT showed that he had just one lung nodule in his right lower lobe that was enlarging. And it was positive here on the PET, lighting up. So we know what's going on. This is progression, but it's only at one place. So this is oligoprogression. He was referred to me for an ablation. And so I had to think about, how am I going to get these ablation probes into his chest? The first thing I did was flip him over upside down. So he's laying on his stomach now. And I have access from his back to get these 2 ablation probes positioned around the nodule with this sort of a chopstick technique, where I'm going to be able to get an ablation here and an ablation here that together will encompass this nodule. And so I'm feeling pretty good. I've got my probes right where I want them. I'm starting to do the freezing treatment here. But what I start noticing is this black air around the lung, which is the pneumothorax, where air leaks out of the lung and the lung kind of partially collapses. So how am I going to deal with that? Well, what I did is I put a little catheter into the pleural space here that I can use to kind of suck the air out if I need to control the size of the pneumothorax and keep the lung inflating, keep him ventilated while I'm doing the procedure. And that worked quite well. In fact, what I was able to do is use that catheter to control the size of the pneumothorax and keep the edge of the lung away from the chest wall. So it protected it from the ice. Otherwise, I would have been ablating this rib, which sometimes is a sacrifice you have to make. You sort of ablate those intercostal nerves and end up with a little bit of numbness. But in this case, I didn't because of that pneumothorax. It sort of protected the chest wall. So it's a bit like when you are running and you stumble, but then you kind of recover and you pretend like you meant to do that. So that's what I kind of told my residents. Oh, this is my technique for preserving the chest wall. And here's what it looked like afterward. So you can see all this nodule is kind of now partially obscured by some hemorrhage. There's always a little bit of bleeding into the lung that's expected. So that's a good look. That's what I want to see afterwards. He did end up with a chest tube because of that pneumothorax, but I removed it a few hours later in the same day, and he was able to go home without one. And I just recently saw him for follow-up 1 year later, and this nodule is looking pretty good. This is what I like to see, a nice little scar. Sometimes there's a little bump, a little nodular component in the scar, but there's no sign that that nodule is growing back. And he's also doing well otherwise, not progressing anywhere else. But if he did need another ablation, we could certainly do one because studies have shown, as Drew alluded to, that ablation really does not affect the lung function. These are the different markers of lung function that you get on pulmonary function tests. And what we see after an ablation is no change, no decrement at 3 months out to 24 months. In fact, some measures get a little bit better. And that's because patients with COPD sometimes have very spongy lungs that actually benefit from some of the ablation effects. So that means we can do as many ablations as we want. We're not limited. In fact, this was our all-time champion that me and some of my partners both treated, who underwent no fewer than 20, had no fewer than 20 primary lung cancers that were all ablated over the course of 6 years. So some of the advantages of thermal ablation, it's repeatable, it preserves lung function, it really limits your downtime, the recovery is pretty easy and there aren't a lot of complications. And it can be a good treatment option following primary surgery or radiation. All right, that's kind of it for my slides. I'm going to stop sharing there. And
I can start tackling questions while others are coming in.
yeah.
All right. First one I see, Ken asking, what role do patients have on the Friday sessions? So that's going to be our multidisciplinary conference. So from 8 to 9, we have a closed session tumor board where we go through a bunch of different cases. But from 9 to noon, it's actually a clinic. So each patient sits in their Zoom waiting room, and basically they have 4 appointments. They have an appointment with a medical oncologist, radiation oncologist, surgeon, pulmonologist, and sometimes a 5th appointment if interventional radiology is indicated. So their role is to actually be the patient to get all those consults in a one-stop shop. Next question from Robin. By the way, so glad you're here. So would this therapy, such as SBRT, be used if a scan showed ill-defined nodular opacity in, for example, the right lower lobe? So again, we can only aim at things that are visible, and the uncertainty is often if what we're seeing is even alive. And second, if it's alive, is it just smoldering and shedding and causing problems, or is it just sitting there quiet, under control? And this is the $1 million question, or the biomarker companies would say $1 billion question, is to be able to predict what that lesion is doing. So I think liquid biomarkers is going to get us to a place where we have a little more certainty or less uncertainty. And repeat biopsies are often used as well. And the one thing to know is that we do often get complete tumor eradication with the more contemporary TKIs for ALK-positive metastatic disease. And so it's very possible, and this is what makes our tumor board conversations rather challenging. It's very possible that what we're looking at actually is just scar tissue. So just like ablation and radiation, drug therapy also takes tumors and turns them into scars that can be radiographic wisps. So sorry, I don't have a clear answer on that one.
Drew, on that subject, how do you think about PET positivity? If it's positive on a PET scan, does that push you to want to treat it?
So if it's PET positive and they haven't gotten any ablation or radiation, it's just, just TKI or chemotherapy, to me, that tells me that there's active disease that's resistant. And to me, I want to treat it. I don't know why we sit on these lesions other than to know that we just don't know what the invisible, is it just a tip of the iceberg? So that's where I think, so probably there's a lot of patients who don't benefit from local therapy, but a lot do. And so therefore safety should always be first. So if a lesion's in a safe area and the patient's willing to kind of, do everything they can, then I do favor treating lesions with residual PET avidity.
And can I jump in and ask you too then, what do you typically recommend for frequencies of PETs? We know CTs we usually do quarterly, and then there's some that don't have, they have PET scans at diagnosis and then not again till progression. Some have annually. I kind of like one of my scans every year to be a PET just to be sure that everything is being picked up. What's your philosophy on that, if you don't mind me asking you to?
I'll start with Dr. Quirk.
Yeah, well, I think there's no, as you say, there's no hard and fast rule about it, and different oncologists have different practice patterns on that one. I would say that a PET at diagnosis is a good idea almost universally. And I think if you're considering LCT, a PET before LCT is, most people would say, is a good time to get one. Other than that, I think people have, different thoughts. There's a little more radiation from a PET than you get from just a CT scan, so that's another consideration. But I think for me, I kind of alternate, do a PET CT alternating with just a set of CT scans.
So as an oncologist, lining up with our medical oncologist, we generally follow with CT scans. So we're seeing our patients, every 3 months. And if there's growth or uncertainty, that by itself is sufficient for progression to switch therapy. But as Matt mentioned, I will get a PET when I'm looking at a wispy thing to see if we can just, so sometimes patients, I think, just say, I've had enough. I've had enough of this TKI. I just want to treat everything that's visible. I'm not going to chase things unless it's glowing at that point. So if it's glowing, we'll go for it. It's convenient when there really is 3 or less, but usually most patients have more than 3 things on the scan. All right, next question. So Tuan asked, if a patient is considered as NED, no evidence of disease, is that patient still a candidate for LCT? So no evidence of disease would mean the scan is completely negative. So there's no visible targets, there's nothing to aim at. Sometimes they may be considered NED if they see, again, these scars that they assume are negative. And in that situation, again, if the PET's also negative, it's very unlikely anyone's going to want to treat those lesions. But if the PET's positive, it could be considered. Next question is from Richard. How large of a target can you treat? Well, size is one factor, but also location. At some point, radiation therapy, if the tumor is more than half of one side of the chest, we can't deliver super high doses to that big of a target. So I'm talking about like a 10, 12 centimeter tumor. If it's all confined into one lobe, a lobectomy might be a reasonable option if the drugs are no longer working. And then, of course, location, if they're small, close, even when they're small, if they're close to like the esophagus or the brachial plexus up in the collar area. So all those things that might be as safe. So again, you really want an expert team to look at this. And size by itself isn't a definitive factor.
I would say for ablation, size is very important. Ablation really is most effective up to about 2 centimeters. pushing it up to 3 centimeters. When you get above that, I start to really not want to do an ablation because it's the effectiveness goes down and the likelihood of causing a complication goes up. But Drew, I'm curious to ask you, under that, so for tumors under that 10 to 12 centimeter cutoff, does the literature show any difference between a 6 centimeter tumor and a 3 centimeter tumor? Would those be sort of equivalent?
No, I've never really seen size in the in the regression model in the LCT literature. It's usually number of lesions for some reason. We just know that we know that the local tumor control probability from other literature, for example, for non-metastatic stage 1 or 2, where it's like, 3 centimeters, 5 centimeters, 7 centimeters. And at some point when the lesion is too large, if it's more than 7 centimeters, we really shouldn't be giving 5-fraction SBRT. If we just slow it down to 15 treatments, very well tolerated, we can generally get 90% tumor control, even for a 10-centimeter tumor. All right. Next question from Yvonne. Hi, Yvonne. So I love your question here. So when should a patient consult one of us, a radiation oncologist, right when you're diagnosed or later? Okay, so my answer to this, and I know I'm being recorded, is when you suspect your medical oncologist would never refer you to a radiation oncologist. If you trust that your medical oncologist will know when it's time to talk to us, then you can stick with them. But if not, it is absolutely fine to say, look, I want a second opinion from a different type of oncologist, and we'll work with you. I've had some patients who saw me at the very beginning, and I want to give a caveat about LCT. So we noticed that they meet me in the beginning and they got like 15, 20 lesions and they've never gotten any treatment at all. And so the question is whether radiation would ever be in their future. And what happens is they go on drug therapy, and if they do really, really well and they get a few lesions, yeah, we can sweep the rear and clean it up per the patient's preference. But when it doesn't eradicate all the disease, and now they went from, let's say, 15 lesions down to 12 lesions, there's this disappointment that all of a sudden everyone is having to manage, not just us as the oncologist, but the patient and the family, because there's expectation that if I would do really, really well, I would get this life-prolonging radiation therapy. And I don't think that's the right way to go about it. So I've stopped seeing patients at the very beginning because I trust my medical oncologist to refer the patients to me when there might be an opportunity to treat something that's growing. At UCLA, our paradigm is to treat progressive disease and not remnant disease until studies like Bright Star show a positive signal, enough of a positive signal that we know that zapping remnant tumors makes a difference. So Yvonne, I hope that helps. All right, Wendy has a question. Using Bright Star philosophy, how long do you wait from initiation of TKI to LCT, knowing that maximal effectiveness of TKI may take weeks to months? So this is really interesting. So I'm advising a very large phase 3 trial for the first time in my career, maybe in history. One of the large pharmaceutical companies is doubling down and randomizing patients on their TKI for a different oncogene to radiation versus no radiation. And we were having this exact conversation. They're thinking 3 months. Bright Star waited only 2 months. Well, should we wait 4 or 5 or 6 months? Unfortunately, no one knows. And what my belief is, I think that the longer you keep someone a TKI, the more information you get about the sensitivity of these tumors to then stratify. But just kind of running real quickly to try to get the radiation as quickly as possible, or ablating everything or resecting everything. My personal opinion, my professional opinion is I don't think that's the best way to go about it. So I think a little bit longer than 2 months is preferred. My preference is maybe even like 3 to 4 months at a minimum. The next question is for you, Dr. Quirk. Do artifacts from the initial biopsy, blood droplets, et cetera, lead to not effective LITT procedure based on your experience? Do you know about LITT?
I think LITT is a thing for brain tumors. It's like
laser interstitial thermal therapy. Yeah.
Yeah, I don't do that, and I don't think you do that either, Drew. So I don't.
Sorry.
Really sure about that one. But I do see some sort of ablation questions here. So I see Oh, Jeff. So hi, Jeff. Jeff says, please talk about histosonics. Histosonics is a newer ablation modality that's coming out that uses ultrasound where it's entirely external to the body. So it's just an ultrasound applicator that goes in the body and uses ultrasound energy to just mechanically ablate tissue. And there's so many of these new technologies that come out, to be honest. There's always so many new things, and most of them don't pan out to really be effective. This one, from what I've seen so far, seems like it actually is the real deal. And in probably already some places are using this clinically to ablate tumors, but I think it's going to be more and more places going forward. So I think that we are going to be doing, it's called histotripsy. I think we're going to be doing histotripsy at UCLA in the near future. But there's not really data to talk about it yet. So another one says electric pulse therapy. That's another one of these new technologies where it's an ablation using pulsed electric fields to basically borate cells and kill them with electricity. That one I'm very, very skeptical of, to be honest, because as an ablation modality, it's not all that effective. And they try to sell what's called the abscopal effect, where you ablate one tumor and other tumors elsewhere in the body get treated as a result of stimulating the immune system. I have not really seen data showing that that's a significant, that really happens. So I'm skeptical of that one.
I have a question for you, Matt. Do most centers have IR people on staff or not? Because like, would I see someone on my tumor board who might be an ablation radiologist or no?
Yeah, and I see somebody here asking, is ablation widely available? My local team does not do them. There are IRs everywhere, but they're not lung ablation is not everywhere. It's probably going to be more limited to the larger academic centers. But I think most of the large academic centers should have somebody that does lung ablation. So if you think otherwise that you might be a good candidate, and I'm happy to look. I've had some people reach out to me and say, hey, could I be a candidate for ablation? And I'm happy to talk to anybody about that. But
Can you give us an overview of that? Because I'm not that familiar with ablations. I know people have had liver ablations, but in ALK world that many people, what would be some key elements to look at?
To know if ablation would be a
Yeah,
consideration.
for like progression or first time.
Size is the number one. If you've got a nodule 2 centimeters or smaller in the lung, most often that's going to be a candidate for ablation. Small liver tumors are good candidates for ablation. Adrenal tumors can be ablated. Other soft tissue.
Would you hit lymph nodes with ablation, or would you?
Yeah, depending on the location. Depending on the location, abdominal lymph nodes sometimes, as long as they're not near vital structures. We tend to shy away from like cervical lymph nodes. And mediastinal lymph nodes are tough because there's a lot of nerves and vessels and things in there. So,
okay. And then Jeff Sturm asked a question about liquid biopsies. Is there a difference between companies, Dr. Drew or Matt, of your thoughts on any of that? And
we're not quite sure. We just want to make sure they do have NGS, where they do have the resistant panels. We just, different institutions have different contracts with their favorite vendor. So I can tell you what we do use, but that doesn't mean that ours is the better one.
And Matt, if you ablate an area, can you go back and do ablation again in that same area if it doesn't work?
Yeah, you can. That's one of the advantages of ablation. It's repeatable, and that's what we do. And we see that one of those ablations is starting to regrow. Usually we'll see a little bump in the edge that's suspicious, and then we'll just go back in and touch it up. And that's perfect.
And I know this is not anything to do with the brain, but I'm curious. We have a lot of people who have radiation necrosis in the brain. And I don't know what the percent of people who get brain radiation, but in your experience, Drew, what is the percentage, number one, and do ALK cancers have any difference with radiation necrosis?
I don't think the tumor type matters. It's because the tumor is going to respond kind of similarly. It has to do with the precision of the radiosurgery delivered. And I don't know the exact number, but it's size dependent. And it's a low rate, but it's a real rate. And of course, it's a devastating thing to have. A lot of times it can be managed conservatively. At worst, surgeons have to go in and remove the necrotic tissue that just won't heal on its own otherwise.
And it happens like 6 months after the radiation, or
At
what is the
least 6
timeline?
to 12 months later. And so as people are living longer and longer, you get these late developments of necrosis, let's say 2 years later. And it's good and bad. So the bad is that, these toxicities of treatments are now starting to show up years later. But the good news is right now, I just found out the other day that, the lung cancer survivors now make up the largest proportion of people in the US with stage 4 disease. So the bolus of the population is definitely shifting. And so we are now more and more mindful of the side effects that we're subjecting patients to, which comes back to the whole theme of this conversation. Why deliver local therapy if you don't know if it's going to help someone um, in the first place? I do want to answer Yvonne's second question here, which was that Dr. Camage, another oncologist, often talk about weeding the garden. We do as well. And my patients often bring it up probably because they heard it from Dr. Camage. And so since oligoprogression is so ill-defined, that is a number of lesions, how do we know when to move on to the next TKI? The simple way to think about it is there aren't that many more TKIs. So the question is, do you really want to switch to the next TKI too soon when there's a shot that local therapy can keep you on the same TKI even longer? So for example, if there's 3 or 4 lesions growing, and again, we've got these different treatments, so up to certain sizes, for different locations for different ablations, work with an MDT team will match the right treatment for each target. Sometimes we do two. Sometimes we'll do surgery on the left side and SBRT to the right, and then ablation to, the third lesion. Literally, we have many patients who've had all 3 modalities. If that can be done safely, and then there's no further progression for 1-2+ years, then it was the right thing to do. The problem that has us paralyzed right now is we just don't know in whom it's better. And I'll also tell you another issue, which comes back to my answer earlier about whether you should be seeing a radiation oncologist. Unfortunately, the way that medical education is in this country and many, I think, around the world, each specialist grows up in their own specialty. They do their specialties residency, they do their specials fellowship. They read their specialties journals. They go to their specialties conference. They're specialists. And so that's why I really try to see myself as a lung cancer specialist as opposed to a radiation oncologist, so I can look over the wall at what my other specialists are doing and all this. And sometimes I think one specialist just might not be thinking about the other treatment. So Dr. Camage and Dr. Hamack and me Anderson are unicorns in many ways. There's two, I can't think of any other oncologist in the world who are bigger champions for local consolidative therapy, but you don't see that in many other oncologists. There are others, without any doubt, but there's just not that many. So medical oncologists might just be what I call non-believers. And if you look at the history of cancer research, a lot of studies were basically done to address the non-believers. And literally you do a randomized trial of a treatment A that everyone believes in, and the other treatment that's the standard of care because there's non-believers. And so that really, the human factor in the conversations really is an important thing. And I hate to put a patient in a situation where they're double guessing their doctor. And that's where an MDT can take care of all that. Get in front of all your doctors at one time, and we will force each other to share their perspective to get everything on the table and then match the best management strategy for each patient.
Drew, I think that's a really important point because there are people out here right now whose oncologists just are non-believers and have told them, you're not a candidate for LCT. No, we don't. This is stage 4 disease. We don't do local treatment. And I think if you are wondering about this for yourself, a good question for your oncologist is, well, how often do you refer patients for local treatment with stage 4 disease? And if the answer is never, I never do, then that means your oncologist is a non-believer and just doesn't believe in it. So that's the time where you might want to seek an opinion from someone else.
Yeah. And the two questions really on the table here is, should you do it and can you? And the truth and the problem is there are a lot of doctors who they can, and so they just go ahead and do it, and they're not thinking about should you do it, right? So you really want that MDT to answer both questions before you actually get LCT.
I love that. Great point about the multidisciplinary team. I think that's huge. And when you're looking at 2nd opinions too, if you don't have a multidisciplinary approach right now, consider the expert that you are going to. Do they do a multidisciplinary approach? We talk about that in our ALK 101 series. Jeff Sturm actually talks about that in episode 2. And also at our past summit, we had multidisciplinary panels. So definitely things to check out. Thank you both so much for being here. This was a wealth of information. I'm sure we will have more questions that I will send your way. So thank you so much. And thank you so much to our community for coming together tonight. Remember, this will be posted on YouTube shortly. Ivana's out of town, so it'll be me, and I'm not quite as quick as her with editing. So bear with me, but it will be there so you can review, because there were so many great points to catch and review to advocate appropriately and effectively for yourself. And then we will see you all again on September 29th. Dr. Jessica Lynn will be joining us. We missed her at Summit, so we're so excited. She will be joining us. That will be at 5 p.m. Eastern time, so it'll be nice. We can have some of our international community members. It'll be a little early so they can join. So set an alarm now on your phones. We'll also send reminders, but 5 p.m. Eastern time, September 29. And then we'll be back again at 7 p.m. on October 6th. So yes, she will be giving us an ESMO and World Lung update. So we can't wait to see you all again then. But thank you both so much for coming on tonight. It was so great to have you, Dr. Quirk and Dr. Moghanaki. Thank you so much.
Thank you, Doctor. Everyone can unmute and thank everyone.
Thank you, guys.
Thank you.
Thank you so much.
Thank you.
Bye.
Thank
Thank
you.
you.
Thank
A lot to think about.
Thank
Thank you.
Thank you.